Hello, everybody, and welcome to the Bad EM podcast. My name is Daniel Still, and I'm your host. Bad EM stands for Brave African Discussions in Emergency Medicine, and this is a platform we use to try and find African solutions to African problems. On this month's episode, I'm lucky enough to get to chat to Dr. William Mapham, who's the founder and CEO of Vula Mobile. Vula is an app that I'm sure most of you are familiar with. For those of you who aren't, it essentially connects doctors and facilities around the country and facilitates referral pathways between them. For example, if I wanted to refer a patient to a tertiary facility or any other facility to a specific department or specialist, I could open my Vula app, enter the patient details, fill out their clinical details on a pre-populated form that's had design input by the said specialist or said department, enter the reason for referral and what's been done already for the patient, and then send it. And then the accepting department or doctor would get a notification, could then open it on their side, look at what I've sent them, review it, give feedback, accept for an inpatient transfer, or perhaps give an outpatient date, as is appropriate. Or they might say that they don't need to see the patient for whatever reason, either because you've done enough already, or because they disagree with the assessment. In all, it makes the referral process a lot easier, faster, and more accountable, and there's a paper trail that you can refer back to if anything gets lost along the way. As we will hear in this month's interview, Vula has come a long way from where it began, over 10 years ago, and we highlight the windy road that they have had as a company and as individuals, trying to implement a much-needed service in a very complex health system. They have had many challenges along the way, and they will face many in the future, and their journey highlights a lot of positive and negative aspects of healthcare in South Africa. As always, opinions shared are personal and do not represent any institutions that either myself nor my guests represent. So without further ado, welcome to the show, William. Could you start by introducing yourself and giving us some background about yourself and your professional career?
Yeah, hi Dan, thanks for inviting me. And my name is Dr. William Mapham. I'm the CEO of Vula, and Vula is software that connects healthcare workers so they can get patients to the right healthcare. And I guess it's been a long journey to get here. So I graduated in 2002. My real passion is improving healthcare in rural areas, and I'm from the Eastern Cape originally. My home, kind of emotional, is a place called Adelaide. It's near Grahamstown in the Eastern Cape. So my internship was at Califong Hospital, and three of us had vowed to go rural, what was called then. We were quite excited about community service. Not many people were at that stage. And so we vowed to kind of use it in a way that we could actually make a difference somewhere, hopefully back in the Eastern Cape. And so at that stage, the internships were only 1 year. So you couldn't rotate through all the different disciplines within a year. So we divided them up between ourselves, and between the three of us, we could actually cover all the disciplines in theory. And then after 1 year, we went to Madrileni Hospital in the Eastern Cape.
Cool. And then how did you start your professional medical career before Vula?
Yeah, it was a long story. I guess I was the first medical person in the family, so I didn't know really what to expect. And all those career advisory things you do at school all said, do not do medicine. And I should have listened to them perhaps. But having worked in Madrileni for just over 2 years, we then worked for something called the Rural Health Initiative, which was recruiting healthcare workers into rural hospitals because we thought that was the biggest problem at that stage. Then worked for a company called Soul City, and we had South Africa's primetime TV show on SABC1, and there were only 4 TV channels at that time, and there were health messages built into the drama series. So that was using a form of mass media to change health behavior so that people didn't even have to go to hospital in the first place. Then saw that cell phones were becoming a form of mass media. This is back in 2007 when SMSing was cool. And I did a fellowship in Colombia looking at mobile phones for healthcare, worked in Washington with a company making mobile phone applications. This is pre-Android, so this is really early days. I was hired as the SMS expert from Africa. And so that was a whole other adventure, but making Americans skinnier and smoke less was not my dream life goal. So I came back to South Africa and got a job in Hillbrow, which we call rural Joburg. And there we were turning disused buildings into health facilities. So that was a different style of career, but it wasn't really my absolute passion, and ended up having a rock climbing accident, like a life-changing kind of experience. And then went back into clinical medicine, went back to Swaziland, where a friend of mine was running the only eye clinic for the country. And it was the Vula eye clinic, Open Your Eyes eye clinic. And he said he could train me to do cataract surgery within 3 months. But I was a very slow learner. So it took me 10 months. And in that time, I actually learned more about the systems in place. So that particular eye clinic is paper-free. It's got multiple systems. It's all optimized for speed. And it was when I was doing outreach, we would drive about 4 hours to do outreach. And the rural healthcare workers, or rural health motivators, as they are called, had better phones than me. This is BlackBerry days. So the first version of Vula was launched on BlackBerry, actually, in about 2011. So that was the very early days. And then back to the Eastern Cape again. We started the eye clinic at Uitenhage, waiting to get a ridge post somewhere.
In ophthalmology.
In ophthalmology, yeah. And then eventually did, but it took 3 years of selling a PowerPoint to get any funding to build Vula. So that's that was a different story.
Cool. So it's been a long journey that's been mixed with IT and systems and trying to connect patients to hospitals and hospitals to hospitals, etc. And then give us a brief timeline of Vula itself. So it obviously started out referring eye patients to your eye clinic.
Yeah.
And how did it come to this point?
So I guess one part I missed out was that when I was at Madrileni, at that stage you could do family medicine as a remote specialization. So I did 2 years of family medicine, but didn't manage to complete it because I went into public health really with Soul City and so on. So I think that I had that background of wanting to make sure that anyone who came into a hospital could be helped. So that was kind of a driving force there. And then, so 2010, the World Cup was when we had the idea. And then tried to sell a PowerPoint for a number of years. We launched on BlackBerry, and nurses were doing screening remotely. And BlackBerry BBMing the patients to me doesn't even exist anymore. And then in 2013, we won the SAB Innovation Award for social innovation. And that was R1 million. And then we were able to build the first version of Vula. And again, I thought we could do everything with a limited budget, but we could only launch in one specialty at that stage. So it was only 2016 that we managed to get more funding and were able to launch for any specialty that wanted to use Vula. So the first ones were burns, dermatology, and orthopedics. And it's expanded since then into 70 different specialties. So the dream of having a patient coming into a rural facility and having virtual access via that healthcare worker to anything that was available was starting to come true.
And now you said it's 70 specialities. Is it in all 9 provinces?
To varied degrees. So KZN and Eastern Cape are growing the fastest. Western Cape still grows, but it's been going on for a long time. Free State's been pretty solid and slowly starting to grow there. Gauteng is just starting to grow now, along with Limpopo and Mpumalanga. And then Northwest is our final frontier.
All right. And then would you mind just giving the listeners who aren't familiar with Vula just a brief description of what it actually does? Sure.
So imagine if you're a patient going to your GP or your nurse or your clinic. You will go there and in your heart of hearts, this person may not be able to help you. You've got a complicated cardiac condition or a lesion on your skin that you don't know what it is. And your health worker, you wouldn't know this, has got access to Vula. And when he takes a photograph or she takes a photograph of your skin or looks at your heart and sends up information to the specialist on Vula, the patient is now getting a specialist-guided healthcare at their primary facility. So from a patient's perspective, you're not using it, but you're getting the benefit of it. And then the SMS function, good old SMS, I would receive an SMS saying my appointment with a specialist is on such and such a date, or here's some information around my condition. So there's some information that comes back to the patient. But the primary users are at 3 levels. One is the healthcare worker who is seeing the patient initially. So that person is at the coalface. But anyone who's seeing a patient is at the coalface in a sense, because if I'm a specialist ophthalmologist and I need to get a dermatology opinion or a family medicine opinion, I'm the primary healthcare worker in that setup. The next level up is the specialists who receive referrals. So those are the ones that are giving advice or getting appointments at the public facilities. And then at the higher level, you've got the administrators who see all the data, see the referral patterns, see what needs to be done. And then you've got the researchers who can then study the impact and see what can be done in the long term. So it's kind of very immediate for the primary healthcare workers and then semi-long term for the administrators.
Yeah, so it sounds like it's had quite a evolutionary sort of journey over the years as it's developed. And I use it myself, and I think it's wonderful. And also because it creates a record of a conversation, which is a missing piece in a lot of telephonic conversations, because people are more accountable for what they say, and people also tend to be a bit more polite, like they can't really ignore you forever because there's a chain of delivery essentially. Was that a major aspect in your engineering or in your thought process?
To an extent, yeah. So I mean, like we always knew that exactly like you said, the communication was that missing piece. What happens between facilities? What happens between healthcare workers? These are not things that are in a typical medical record. If you get advice from a senior, where did that advice come from? Suddenly you're seeing a patient and treating a patient differently. So that was always part of the thing. So having that chat service as part of Vula was always part of the intention. In the early days when it was only ophthalmology, it was called iMessage, as an EYE message. And so we thought that was very funny. But actually that chat system is, like you've seen, has become very, very useful to more people. And having the chat function used in multiple ways now. So the fact that you can add an allied healthcare worker to the chat, or you can add a professor to the chat. Suddenly now you've got kind of a community of carers around a patient in a sense. So that's been a very special development. And then on the politeness side, I'm glad you raised that, because everything is accountable. So there was one head of department who wanted to look at that, and he was able to look at all the conversations between his department and referring health workers. And he was very happy with the advice, the clinical advice, but he was not happy with the language being used. And so then he created standard protocols for how to be polite to referring healthcare workers. But this never would have been possible without
people don't record their telephone conversations.
Exactly, yeah.
So to move on, when one brings a good idea into an established healthcare system or a space or whatever, not necessarily healthcare, but in this regard is healthcare, what were the main challenges from a systemic level or a bureaucratic level that you faced with Vula?
Yeah, I've got a couple of weeks to chat, so let's start. I think in the very early days, digital health wasn't a known thing, really. It was like viewed as like, oh, that'll be nice one day, but no one was really kind of doing anything about it. And I think it was nice to have that experience in the US, where I was at a startup trying to push the limits of what could be done with a mobile phone in a very different environment. So when we came back here and we first launched Vula and we told the department about it, they really didn't know how to treat or manage us. And for them, it was better just to pretend we didn't exist. We're more of an inconvenience than anything else. And I think what we've worked out is that healthcare, in our setting anyway, is a bit like an hourglass. There are only 7 of us, so you can't have someone attending endless meetings or writing policy documents. So we had to find out what's the smallest amount of effort we can make to make the largest amount of change within a health system. And so what we realized with Vula is that there are lots of politicians at the top, or kind of on the left, and there's lots of healthcare workers at the right, and there's a bit like an hourglass between those two. And the thinnest point of that hourglass is what we call the change agent or a head of department. So if that person decides that they want to change the healthcare system in their domain, it doesn't matter what the department or the politician said, but that person can make a change that will then influence many, many healthcare workers in their environment. So I think the key for us was to stop going to endless meetings and to work out what's the smallest amount of effort we can make to have the biggest impact and focus on that. That was our approach to the bureaucracy.
And you would obviously also have had to pinpoint who that person is that you wanted to target and who would want to adopt your platform to use.
No, exactly. And we made mistakes. So in the early days, we thought that Vula could be implemented by a registrar, purely because I had done that at Tygerberg Hospital. But it was done there at Tygerberg because we had the full support of the head of department. And we didn't realize at the time how key that role was. So when we were asked to go to other specialties, we initially thought, well, let's just ask a keen registrar. And absolutely nothing happened because the registrars don't have any power within the department. So then we identified that the HOD must give consent for this to happen. And he or she, there's no point going to one who's has never been innovative in their lives. You need to find ones that have done something innovative and who care really about their department. We also know that those people are very busy, so we call that the administrative head, and we ask that person to nominate what we call the emotional head or team admin. And with those two people, we can change the entire system underneath that. So it took us a while to work out the characteristics of that person, and we've got better at that over time. So if we get contacted by a medical officer in a department, we don't say, oh, we'll work with you. You'll say, please put us in touch with your HOD. Otherwise, we know it's not going to work. Or if we get approached by a politician and says, please implement it in this area, so the same thing, please put us in touch with the HOD. Otherwise, we know we can't create change.
You sort of have to recognize, well, you have to recognize your sphere of influence and you have to recognize others' sphere of influence.
Yeah.
And that I've come across myself trying to make small changes in departments I've worked in as a medical officer, and then you can't get anywhere unless everyone else also thinks it's a good idea and actually then does something about it. Even if you've tried to do things about it numerous times, it just doesn't happen.
No, it's hard. Change is hard. So I think the other thing we learned through family medicine were things like motivational interviewing, which was exceptionally useful for our approach to how do we change behavior within the health system. So motivational interviewing is a way of asking questions that create behavior change, because in family medicine, the relationship between a health provider and a patient is part of the therapeutic event. It's not just the medication or the X-ray or things like that. So how do you use that as a therapeutic tool? And one of the tools is motivational interviewing. So if I tell someone to stop smoking, it's highly unlikely that they will stop smoking. But if I can attach smoking to something they care about and say something like, what will happen to your kids if you don't give up smoking? I'm not asking for a reply. It doesn't matter what the reply is, but the question itself will start to create the change that you are looking for. So I think we used a lot of family medicine in terms of our behavior change, and then again with Soul City using a lot of the techniques we use then for mass media in our behavior change. So I guess I've been lucky to have those two experiences. Technology is actually the easy part. Behavior change is the hard part.
How to influence people individually and en masse.
Yeah, exactly.
And then how do you, so with technology and medicine and with developing systems and everything like that and telemedicine and all of those things, there's quite a lot of IT systems in play. How do you navigate your confidentiality and things like the POPI Act? There are a lot of new programs, especially with artificial intelligence. I tried one the other day where you can dictate your notes into your phone and then it spews out an ordered subjective objective assessment plan in a very impressive style, which would be lovely to try, but the program is from America and I don't think they've consulted our POPI Act. So, and I don't know, and not that many of our things in our hospital are actually POPI Act compliant. But how do you do it, and what advice would you give to somebody who wants to use new programs in a South African public healthcare setting?
So compliance in terms of us is 100% necessity. It's not a nice to have or why didn't we do that? So very early on, I think we spent almost R1 million on compliance to see kind of how far down the road can we go to be like absolutely perfect. And I think one of the mistakes people make with compliance is not a certificate. I can't get a certificate and say, I'm compliant, therefore I can do whatever I like. Compliance is a way of working. So in theory, you should have an audit and say, are you always managing data this way? Are you treating your own data, your team's data, your professionals' data, your patient data? Are they all being managed in a secure format? And so I think there's a lot of work you need to do. I think in the early days, a lot of stuff wasn't automated. So if you're using AWS, Amazon Web-based services, or some of the other environments that you can switch to, a lot of those do have a compliance option. So you do pay more, but then you get the aspects of compliance that you need, whether it's HIPAA for the US or GDPR for Europe or POPI for us, and there are others. So I think that one thing is to...
Just quickly, are those interchangeable? If something is HIPAA compliant, does that mean that POPI Act, it's POPI compliant?
They all overlap, but they're not all the same. And I think that, because also that they're going to audit you in a slightly different way. But the key thing is that POPI is a very good one. So if you're POPI compliant, you are very close to being GDPR compliant. It's a really good, we've got really good laws here. So I think if you can make sure that you work towards compliance or act in a compliant manner the whole time, then you've got a good chance of doing it internationally if you do it properly here.
And in terms of using other people's software on an individual or departmental capacity, what advice would you give to someone that's not trying to implement a system necessarily, but make use of other people's very nice new software that would make our lives more efficient, like dictation, for example, or note record keeping, or a app on your phone that you could use to make a logbook or something like that?
It's interesting because there's a difference between what you should do and what people actually do. So what doctors and nurses typically do is whatever is easiest for them. So like you just said, like people will use an AI dictation thing because it works and it saves you time and money. But that's obviously putting your data and your patient's data at risk. And that's a choice that individuals would have to make if they're comfortable with that. So for example, there was a case in Gauteng we were introduced to where they thought that they were being compliant by using a Google Doc. And they thought they'd set up in a way that it was owned by the university. So it seemed okay. But actually, when anyone interacted, it was with their personal Gmail account. So no, it wasn't actually, although the people thought it was.
Because that's now going to an external...
Yeah, so all your data is installed outside of South Africa, and they were sending in actual patient details. It wasn't a theoretical conversation. So you have to be careful, and you have to make sure you do the best you can do. And it is possible to be compliant. We've shared everything we've done on our website. So if you scroll to the bottom, there's a legal and compliance section. You can read all about it. On the app, under your profile section, there's more information that you can read about it. We've published on compliance in the South African Medical Association's Insider Journal. And so trying to make sure that people are as informed as possible and hopefully make the right decisions.
When you develop, back to the story of Vula, how did you get the government to pay for it, essentially? Or did you sell it as a product as it got a bit of...
the government's never paid for it.
Never paid for it?
No.
Okay. Who pays for it?
Yeah, so that's been a major challenge.
Yeah.
So if you can imagine, there are 10,000 healthcare workers in the Western Cape that use it every month.
Who work for the government and are paid by the government. And
the equivalent to that, if you bought the cheapest version of Teams for that group of people, that would be R1 million a month. And Vula is way more than the cheapest version of Teams. So it is very expensive to maintain the service and keep it going at the level that it's required to do without government support. Yeah.
So how do you make money? Is it a NGO, or do you get private donors, or?
No, so we structured it as a company back in 2013 because we had to have an entity to receive some money that we had from a donor. And we thought at that stage that donor money would be the answer, and we had a little bit of cash. But I was also working full-time as a doctor and basically funding it myself. In 2017, it did get a bit hairy. We had to sell our car to keep it going. And then in 2018, we got our first advertising contract, and we thought this was going to be the savior. But advertising revenue doesn't increase because you've got more users or because you've got more impressions. There are only a handful of companies that actually advertise to the public sector health workers in South Africa. So you're not flooded with reps every single day. It's not a thing. So actually that market was capped, and we realized that it's not even enough revenue to keep Vula going for a day. So we've actually phased that out now. And then in 2020, we got our first, what we call a health systems contract. So this is for a country outside of South Africa. They wanted to improve referrals for a particular therapeutic area, and then we got a contract to do that for them. And then that led to another one, for example, in Ethiopia, northern Ethiopia. They wanted to fix obstetric referrals in the Gondar University area. They then used Vula as the referral system. They published on their data, and that's available. So I think that we are becoming known as a referral solution outside of South Africa. If there are any contacts in the ministry that would like to actually pay for it, please let us know. And then we also had a couple of data contracts, which we thought was going to be a sort of a third of our revenue. It's only happened in the last 2 years. And so one was with the Clinton Health Foundation during COVID. And a very exciting one was last year with the Global Fund. The Global Fund funds HIV, TB, and malaria. But I was trying to explain to them, if you only fund HIV clinics, TB clinics, and malaria clinics, you're not going to reach all the patients with those conditions, because patients have to make a choice.
Go to a normal clinic.
They'll go to a normal clinic.
Specifically go to something where they, yeah.
No, exactly. And if you've got a broken leg, do you go to your HIV clinic or do you go to the orthopedic department? These are choices that patients have to make.
Even if you have HIV, you're going to go to the orthopedic department, or you're going to go to a casualty, actually,
yep.
An emergency unit.
Exactly. And there's no services there. So then we showed them an analysis of where they could pick up the most patients if they had services linked to different specialties. And interesting things came up, like ophthalmology, dermatology, where the presentations of HIV are quite early compared to what someone who's got really, really sick before they go to a internal medicine or emergency room. And things like endocrine surgery, who would have known? Right? That is a huge focal point for patients with presenting with HIV and TB. So I think that the data is becoming more useful, and there's been 11 publications now on its impact. So I think that will grow, but you have to then find people who are willing to think beyond one specialty. It's been a major, major challenge for us. There are really no health systems funders
that want to attack or want to target a whole health system and improve the entire efficiency of a whole system, as opposed to our charity is for TB medicine, or our charity is for children with malaria, etc.
Exactly. So even like the Gates Foundation does HIV and TB. If the TB is presenting in ophthalmology or endocrine surgery or psychiatry, that's not a thing. So it is a real challenge for us anyway to find people who think truly systems level. If anyone's listening and those people who are able to think that broad, please let us know.
It's quite ironic that you have built this product and now you are a referral system specialist that other governments are paying for to fund your work in South Africa that we are not paying for ourselves.
Yes. I think South Africa is tough because every province has its own Department of Health.
Yeah.
And then we have the National Department of Health. So it's complicated here. So in a way, South Africa was a good learning space because you have to work in 9 different ways to do one thing. So I think that's been a has been a challenge. And then also, who has access to the budgets? Because the change agents or as heads of departments, initially we did charge them small amounts, but we realized they were taking money from research budgets, and we just weren't comfortable with.
It was money that they had access to.
Yes, but they were for equipment or for people, and it just didn't feel right that they should be paying. It's better for their bosses to be paying, but we have never been able to identify the bosses in the Department of Health that would spend money on external innovation. Often what a department would do is it would allocate budgets internally towards innovation, but they wouldn't accept anything external. So you'll see there's multiple apps that have kind of tried to go public and then quickly reverted to private because actually they can have a business model there. Yeah.
And in terms of, so you've obviously got your people that you target to implement the system. In terms of a permission sort of thing, does the department or the provincial department still have to say, yes, you're compliant, yes, you're welcome to carry on, but we're not paying you? Or is there none of that? Is it just the HOD saying, okay, you've got we can see that you're compliant, I'm happy to have you work in our department?
So a good example is the Eastern Cape, where we have an MOU with the department, which then enables us to work within the province. We still ask all the HODs to write a letter of support, just that they also covered and everyone's aware of what's happening. Another example in Gauteng, which can be a little bit more chaotic, but the head of their IT system wrote us a letter saying, please, can Vula be used across the province? Therefore, we've got kind of authority. In the Western Cape, we don't have any official mandate, but we do work very closely with the heads of departments who use Vula.
So the head of IT or the head of information systems in Gauteng, can't they apply to pay you if they've officially asked you to operate for the whole of Gauteng?
I hope so, but I haven't discovered a way for them to do it. Yeah, but again, you've got to realize the 7 of us, and like, where do we spend our time? It's actually easier for us to find funding outside than to have a long shot on maybe having a government contract. We don't know. But maybe happy to take advice.
But also, yeah, it comes down to also developing a very desirable product and then possibly trying to monetize it as you go, as opposed to trying to ask someone to pay for it from the beginning.
Yes.
And would you ever, I don't want to give you any ideas, but would you ever, you would obviously have to stop doing it if you ran out of funding. That's no question. Would you ever force the issue by saying, this is the service that we provide, this is how much time and efficiency we've saved, these are all the publications that have come out, and this is the data, we would have to stop unless you start paying us?
Oh, we have begged the department, but they would rather it stop. So
it's a pity.
Yeah, it's hard to. Yeah, so we go back to fundraising for ourselves. Yeah.
All right. So you have obviously been through a personal journey and a collective journey with Vula in terms of trying to implement change throughout your medical career from when you were a student to now. What advice would you give to a young person who spots a gap in whatever system that they are trying to fix, if that is a small gap or a big gap, and would like to focus on a specific thing that they are trying to achieve? What advice would you give them?
I think there 2 things I would recommend. One is, I didn't get into medical school the first time I tried, and ended up doing a BSc, and then one of the courses I hadn't done biology at school, it was called Biological Diversity, and Professor George Branch lectured at UCT. Absolutely incredible lecture. Lecture before lunch, the death lecture, and no one would leave until all the questions had been answered. And his whole approach was how remarkable systems were. And so ecological systems are incredibly complex. And I think all of us who did that course and then went into medicine all did something systems-wise as part of what we did. And I think having that mindset, and it's yet to be completely open because you don't know, you can't really easily define what's going to happen if you change one thing. And so I would definitely recommend people finding a way to study systems, but not medical. Try something, whether it's data systems or AI approaches, neural networks, or biology, or even geography, something kind of outside of medicine. So just to kind of change your own internal mindset, even if it's just unconsciously. And then when you come across that tiny thing that you want to change, be aware it's going to have huge ramifications. It's not just one thing, actually. And if you can have a demo that does that thing, prove a case in one place, and it'll be much easier for you then to grow. But create a demo. So the first version of Vula was on something called Productivity on Paper. It looked exactly like an app, but all it really was a series of screenshots that I'd kind of paddled together, and if you pressed on a button, things happened. And so that actually was the one that ended up, winning the award and giving us money and everything. So I think that if you can prove the case with as little funding as possible, and once you've proved it, then apply for funding to expand it. It's much easier to get funding if you've done something than for someone to have a go on an idea.
Yeah. So start very small, get data on a small intervention, and then try and expand it from there.
Yeah, that would be my approach. The nice thing about digital is that if you do have something that is relatively small, you can launch it in a big way relatively quickly. So what you could do is use like the lean startup methodology, where you don't even have a product and you sell it. You say, like, who would like to buy a Tesla Cybertruck? It doesn't exist, but everyone puts in the money, and now you've got funding to actually build the Tesla Cybertruck. So there are ways of doing digital interventions like that, where you sell something in order to fundraise for it. But yeah.
So in South Africa, as you know, there's without exact data, but there seems to be a increasing demand on our healthcare system, an increasing burden, and a plateauing or stagnant provision. There are budget cuts that are not, people aren't getting hired. There are no bigger centers being built. The systems are, the computers aren't being upgraded, things like that. There seems to be a very stagnant expenditure in terms of improvement and maintenance. Technology does seem to be quite a light of hope in terms of making what we do have more efficient. How can we move as a profession towards utilization of more technology and better technology?
So I think there's two parts to your question. One is kind of how do you make the system more efficient? And the other one is that how do you make technology achieve that? And it's not always the answer, but I think if I can give you kind of a mental picture, you've got the Zeitz Mocker Art Museum in Cape Town. It was a set of grain silos. You can't have a museum inside a set of grain silos. It doesn't work like that. But they hollowed it out to make the art museum. So it was a deconstruction. I actually met the architect. He said it wasn't a construction of a art museum, it was a deconstruction of grain silos to make an art museum. So you took things away and you make it way better than it was ever like before, like 2 years before. Same with healthcare, we need to do similar kind of things, have that kind of attitude of what can we take away to make things better. And the other example is a theory of constraints, where there was a car manufacturer that always lost the Le Mans 24-hour race. And then they worked out their car was slower. So then they had to say, how do we win the race with the slower car? And so they converted to diesel.
Not how can we make our car faster, no. How can we win the race with the slower car?
So they converted their car to diesel, they had fewer stops, and then they started winning the Le Mans 24 hours with a slower car. And so I think that if I can give two examples, those kind of attitudes to take. So let's take something like ophthalmology, which is my specialty. In South Africa, we have ordinary healthcare workers and we have specialists. There is nothing in between. So ophthalmology referrals are very, very high in whichever environment you are in South Africa, because there's no middle ground.
Yeah, there are very few medical officers who know a lot about ophthalmology.
Exactly. Whereas if you look at like Namibia, Botswana, Malawi, Rwanda, Kenya, they have what they call ophthalmic clinical officers who manage virtually everything for ophthalmology in their area and only refer the very serious ones through to specialists. So you're not using your specialists as primary healthcare workers anymore. So things like that, just for ophthalmology, where you can make a systemic change, but it does require a change in approach, because often then you're going to be fighting politics or procedures. There's going to be who trains these people, why they're being trained, are they going to take jobs away from other people? In Malawi, people who do cataract surgery are called cataract surgeons. That's what they do. Whereas to become a cataract surgeon in South Africa, you have to do medical school, you have to get selected for your Reg program. Only then can you, but no one is selected for a medical school in terms of hand-eye coordination. That's not a test for medical school.
Yeah.
So imagine if we had 20 or 30 cataract surgeons in South Africa, we'd quickly get rid of the burden. So I think it's not a case of like, how do we match our demand with a diminishing supply of resources? I think it's a case of we can be really clever. I don't think there's anyone in South Africa that will claim that the system's operating at 100% efficiency. So there's a lot we can do. If you go to many government clinics, not always, but sometimes they'll be finished by 3 or 4 in the afternoon. You've got an extra 2 hours. What are you going to do with those extra 2 hours? Or you've got private sector who are not giving opinions back to private GPs because otherwise they might lose the patients. So there's so many ways we can create efficiencies. And the one thing we know about South Africans is that we always make a plan.
Yeah.
And so I think we've got an incredible opportunity. We do have financial resources that cannot be compared to the financial resources that we've seen in other African countries. We are so spoiled. So actually, if we can't solve our own problems, given the resources we have, then we deserve to be kicked in the butt. So, yeah.
I actually worked a bit in Malawi, and I'll testify to the fact that those cataract surgeons, I spent a couple of days in the eye clinic there, and I asked one of them from an emergency side, since I had such a good view of the eye and the anatomy, and the patient was there with nice machines and everything, I asked them to explain how to do a lateral canthotomy. And he'd never heard of it, didn't want to speak about it, he's like, I don't know what that is, or why are you asking me, but I can teach you how to take out a cataract.
Yeah. Yeah, exactly. So they do one thing and they do it really well, releasing the burden, which means the specialists get to see the things that they're supposed to be seeing. You asked about how technology solves the problem. So I think that technology it can do 2 things. One, it can make things less efficient. So, for example, an easy way to describe that is www for a website takes less time than to say World Wide Web. Sorry, more time than World Wide Web. There are fewer syllables. So technology can actually make you less efficient. And there are some cases people refuse to use medical records because it actually wastes their time. So that we do have the opportunity to make a problem with technology. But if you can find ways to reduce the burden, then that's where technology has a place. So imagine if a patient arrived and the history had already been taken as you saw the patient, or the patient, while they're waiting in the queues, are learning about their condition because they're sitting there for 3 hours. So by the time they arrive at your consultation, they know exactly what diabetes is. So now you've improved the healthcare system, hopefully prevented someone coming back. So I think there's so many ways where technology can be used. And the nice thing is all the patients have got really good phones. Most phones are basically mini supercomputers compared to what we had in 2007. So there's so much opportunity. And I think that what we don't have in South Africa is something like the Health Tech Hub in Kigali in Rwanda. So we are part of that. And it's an incredibly strong network of all the different digital solutions from across Africa. And what the Rwandan government has said is that they want to learn from everyone. They need to understand how they can best have efficiencies. It would be great to have that same thing in South Africa, but currently it doesn't exist. But the nice thing about that is the ministers come to the presentations. So what they said to us is that, look, the policies are never going to lead the technology. They'll follow as closely behind as possible. So I think that's an incredible example of what can be done, or a different approach.
Just to comment on that, like one of the very easy interventions I've found, like you said, with patients having access to the internet and phones and everything, instead of a discharge summary that doesn't make sense to a patient, that might get lost in their drawer or might never go anywhere. You just tell people what to Google. You write down their condition, and instead of giving it to them, you just say, Google that, and then you can read it about it in your own time, watch a YouTube video.
No, exactly. Or what you can do now is you use the Vula SMS function and send the patient the link that you want them to look at. Otherwise, they might Google the wrong thing.
It's empowering that people have access and people can
Exactly.
read and people have literacy. So health literacy is a natural step from there.
Exactly. So I think you're working at Victoria Hospital. So I was there as a student, and we wanted to look at what are the stories that are told in hospitals. So we sat at the
some good ones.
Yeah. Well, we sat at the exit and we interviewed patients and say, what do you think you have? Like, what did the doctor tell you? I think two of the ones that were sticking in my mind was, one is a person that thought they had ammonia in their lungs rather than pneumonia, which is quite common. And the other one is a thing called a varicocele, which is a problem with your scrotum. But the patient thought that he had a voracious seal in his left scrotum. So I think that sounds very emotive. So I think that what doctors say and what patients hear and the stories that go around, there's a lot of work to do on our communication. I think that's where technology really can bridge some gaps. Because if you've got 9 official languages and many others, and you've now got doctors who don't speak 9 official languages, what's being shared? I think that's such a key thing. And like you said, if you can share links that have appropriate languages or explanations, and it's the right links, so it's not Dr. Google, it's
correct.
That's the thing, yeah.
And like you were saying earlier with the motivational interviewing, the health consult is so much more than what the physical service you're providing it. The service is enhanced so much by the emotional connection that you make, and that the outcome is so much improved by
absolutely
good communication.
I think there was a case at Matabeleland when we got students to come and join us, and the students were used to working in a city, and I overheard one of the students telling a patient to come back the next day, but I knew where she lived. It was about a 5K walk, so this is not something realistic. So we quietly went and saw the patient, managed everything, and then we took the students to local backpackers and said, look, we'll give you a free evening in the backpackers. And they thought this was amazing, and they had a lovely time. And in the morning they said, oh, can you come pick us up? I said, no, that's where the patients come from. So then they had to walk 3 kilometers, convince the boatman to take them across the river, walk another kilometer, catch the taxi, which may or may not be there, up to the hospital. And after that, they never tell someone to come back the next day. So, yeah.
And that also, I spoke about it in one of my previous episodes or 2 of them actually, with the first and the second with Almiro and Clint Hendrickse. People need to think about the patient's healthcare journey as opposed to their interface between you and the patient. Like, where's the patient coming from? Where are they going to next? And I think Vula speaks a lot to that need and addressing a patient's healthcare journey in terms of connecting them to appropriate care with a documented pathway.
No, absolutely. So I think that we didn't know what would happen when you improve this communication, but the studies that have been done showed that when Vula is used, you can reduce the number of patients traveling from rural clinics to tertiary hospitals by an average of 30%, which is huge, especially for patients who may not have transport easily available. So I think that was kind of a key finding that we really like to see. Yeah.
And that's mainly specialists giving advice to the primary caregiver and reducing that need, or specialists saying that is just not necessarily something that I need to see.
It can be either, and often what a primary healthcare worker thinks is an emergency. So there's something called a subconjunctival hemorrhage, which looks absolutely awful. It looks like a person's become a vampire. But actually it's not needed. A referral isn't needed, but it does often take some calming down of the primary healthcare worker and the patient, yeah.
And then are you working on any other sort of services at Vula or integrating different technologies at the moment?
So we're always building. I think that's the key. The one feature set that we're working on now is making the web version of Vula a whole lot better. And the other one we're looking at sort of as a primary one is about some sort of AI around dermatology cases. But it's more of an experiment. So we still have small experiments as we build. And then we're always responding to users. So often people request, like the SMS function that we had, well, we didn't have to, but we made for the users that wanted it, better analytics. So yeah, it's like, I think sometimes people think that technology is like a house, you build it and then you've got it. But it's like putting water into a dam, and if you pour more water in, sometimes you have to take the water out because it was a feature that was unneeded. And if you build something you think is a foundation, it's not. It's just it's code that is lost and you'll never use it again. So I think that always building is kind of maybe our mantra, and always responding to the users. So rather than trying to say, what are we going to build ourselves, trying to look at what users are actually doing and then adjusting what we do to make lives easier for them.
Last question, unless you have anything else. If you had a magic wand and you could wish for one tangible systemic thing in South African healthcare, whether that's a new nice big hospital, or whether that's all doctors to be friendlier, or or all patients to have better insight, or anything that you want, what would you wish for tomorrow?
What I would look for is an entity that would have helped me at the beginning, but would also help me now. So what I would say is a big innovation fund for healthcare in South Africa. So very, very broad. So whether you're educating patients or whether you're building a hospital, anything along that line where you can have what's called a flash grant. So we had one from the Shuttleworth Foundation, which really helped to fast track our growth in the early days because someone believed in what we were doing. So there you're looking kind of like 50,000 Rand, almost a give it a bash style funding, and doing a real shotgun approach because you've got really no idea like what's going to work out. But it's enough for someone to prove a point. And then building that up, having a fund that can actually say, this is great, we're going to scale you now. So we haven't discovered something like that in South Africa yet. But imagine then if one of these things did work and then it could be funded to scale within the public sector. So I think there's lots of things that will fund in the private sector because there's direct financial reward.
That, yeah.
But in the public sector, we haven't seen an entity that can do that. There are sort of isolated ones like TIA, which is Technology Innovation Agency. There's the SAB Foundation, which has been incredible for us. They do way more than health. And so there are kind of isolated ones, but I think if I had a dream, it would be to have this entity and be able to create innovation across the country. I think there's so much we can do, but you do need to have a systems level approach rather than saying I only fund HIV or TB. Yeah.
And people that have good ideas could then not have to sell their car to try and prove it works.
Yeah, that would be very nice. Yeah.
Yeah. Cool. Is there anything else that you want to add or speak about or ask?
I think that, thank you so much for this platform. And if there is anyone out there who does know someone who likes to fund health systems, especially in the public healthcare sector, that would be exceptionally useful for us to be put in touch with them. What we can guarantee is impact and numbers and scale. And so we're looking for someone or people that are able to think at that level and have the capacity to act. And I guess that the other aspect is that are there individuals that want to support individual departments? So, for example, your department, is there someone that would like to support emergency medicine at Victoria Hospital? We can go down to that level of granularity. So yeah, we're excited about the future and hopefully we get some callbacks after this.
Try and spread it far and wide. But thanks so much for joining. And yeah, I really appreciated that conversation. And I'm sure our listeners will find it very interesting.
Thanks, Dan.
That's all for this month's episode. I really enjoyed that conversation, and it really shows that good things take time and effort to start as well as to maintain. And despite lots of challenges, there are people that can navigate these in a way that benefits the health system in general. If you would like to get in touch, please do so. Email me at dan@badem.co.za or visit our website www.badem.co.za for more content. Remember to like and subscribe on all of your main platforms, and share with friends, colleagues, and even politicians who may be interested in this episode. See you all next time. Bye bye.